Welcome to the Taylor Method for Pain-Free Living, a podcast that features enlightening conversations with experts in the medical field that helps to improve the health and well-being of those suffering from chronic pain due to injury. Learn from leading authorities the questions you should be asking to experience pain-free living. Hosted by father and son, Dr. Derek Taylor and Dr. Hudson Taylor, and joined by industry professionals in the health field, including doctors of integrative medicine and personal injury attorneys. Enjoy well-rounded and informative conversations to help you get out of pain while achieving optimal wellness. Dr. Derek Taylor and Dr. Hudson Taylor are the doctors of Taylor Chiropractic and Laser Center in Florida and California. Both father and son duo have earned respect and a solid reputation for successfully helping people transform their lives by assisting them to discover the hidden causes of their painful health challenges, leading them to experience the resolution of their problems using the Taylor Method. Tune in each week to learn about the Taylor Method, Dr. Taylor's proprietary technology that looks at the whole person and identifies the root cause of pain while facilitating natural healing and helps to restore the body to optimal wellness without using drug injections or surgery.
Well, welcome to the Taylor Method for Pain-Free Living show. Our guest today is Dr. Clifford Stermer, who's a board-certified rheumatologist as well as internal medicine doc. He has been practicing in Albuquerque, New Mexico since 2012. Was that, Doc? And,
I did a internal medicine residency in New York at NYU. And then after that, I was in at Rutgers University for rheumatology fellowship.
Okay, great.
And then in 2017, I went to Albuquerque, New Mexico, and I was there for many years. And now I'm your neighbor here in Florida. So
Great, yes. And
I'm at One Rheumatology in right near you in
Palm Beach Gardens. Yeah. So you in 2021, you won an award, that top rheumatologist there in New Mexico, voted by your peers in the Albuquerque magazine. Then you were voted again this year, even though you don't live there anymore. You're in Florida.
Yes,
so
that's
congratulations. It's quite an accomplishment.
Yeah, I was there for half the year. So that
counts.
And I still actually do virtual visits and consults with patients in New Mexico.
Oh, okay, great.
Yes.
Well, you're just a computer click away then.
It's definitely opened it up, to be able to see people virtually, not as good as seeing them in person.
Right. Right. Well, we're very fortunate to have you here in Florida. So tell us, what does a rheumatologist, tell us about what makes a rheumatologist different from other specialties?
So rheumatology is these days is practiced as treating inflammatory disease and specifically treating autoimmune conditions. So an autoimmune condition is when your body attacks itself. And, we all have an immune system, and we want that immune system to fight things like COVID and infections and urine infections and the flu, or help us heal. But when your body turns on itself and you recognize your body as foreign and your immune system starts attacking your own tissues, that's where rheumatologist comes in. So
yes, and how prevalent are autoimmune conditions that you see in your practice? Is it a pretty common occurrence that you're seeing in the general population? Is it on the rise? What are your thoughts on autoimmune conditions?
It is, well, first of all, things are recognized more, right, and being classified more than they used to be. So, but the prevalence is about 1 in 6 people at some point are going to have some type of an autoimmune disease. And many of those people end up in rheumatology. Some other specialists treat autoimmune disease also. Some common ones would be an endocrinologist who treats autoimmune thyroid disease or Hashimoto's, or a gastroenterologist who would treat Crohn's disease or ulcerative colitis or inflammatory bowel disease. So other specialists also treat autoimmune disease, but a lot of them end up with me in rheumatology. And then many times when you have one autoimmune disease, they tend to piggyback on each other. So you could have others
Oh, yeah. So that's what I see commonly in our office is that if somebody has one autoimmune condition, they usually have another or even two, just because it's basically the same mechanism. Body's attacking itself.
Yeah,
And if it's going to attack other tissues and other organs or areas, it's going to show
exactly.
up, right?
Yeah, so some of the main ones that I treat are rheumatoid arthritis, which is inflammation of the joints. But rheumatoid is a systemic disease, so it affects your internal organs, your lungs, and you have generalized inflammation all over. But it's recognized by swelling, usually of the smaller joints, and then other conditions like lupus, and that comes from the Latin for the wolf, or Spanish would be the lobo, and the French would be the loup, right? And it all comes from the wolf, and it got that name because it could kind of pop up in any organ. So some people have lupus where your body attacks your skin and your joints, and you get a rash and joint swelling. Other people have lupus, in the kidneys. And where it could attack your kidneys, it could be in the heart or the lungs, the areas around those, even the brain. So I like rheumatology because you are dealing with all the body systems. You have to do internal medicine first. You have to be a fairly good internist, and then you take it to that kind of next level. That's what made me most interested in it. The next level being seeing, really diving into the immune system.
Right. So how does one determine if they have a rheumatoid arthritic condition? Let's say they have an issue where it just have a pain in the joint or an organ is being affected. You're in your workup. How do you determine, other than blood work, that they are dealing with rheumatoid arthritis?
So a lot of people have arthritis, as you see plenty of arthritis in the back and the rest of the body, and generalized osteoarthritis, as it's called, which just means degenerative changes, things get worn out over time, right? So people have knees and they get knee replacements or hip replacements, or little nodules on the fingers, or their thumbs hurt kind of in the base of the thumbs. Those are classic places for regular wear and tear osteoarthritis. But rheumatoid arthritis is inflammatory arthritis. So there's different ways to kind of see that, but it goes to different parts of the body and it affects different people at different points in their life. So a lot of the autoimmune diseases, it's very much a young person's disease. You can get rheumatoid later, but when you see somebody who's younger coming in with a lot of joint pain, that's a red flag. The other thing is it causes joint swelling. So you see inflammatory changes, red hot swollen joints. And their blood work would reflect inflammation also. And their blood work could also reflect rheumatoid factors being positive. So there's certain blood tests you could do. But just the telltale sign when you see someone or they describe their symptoms, regular osteoarthritis or wear and tear, that hurts when you're using it. Mm-hmm. So you're doing squats, you're walking up the stairs, your knees hurt. And those things get better with rest. Whereas inflammatory arthritis, they hurt more with rest. You wake up in the morning, you're very stiff. You're stiff in the hands, you can't hold your cup of coffee. And they get better with use. So that's kind of a main question I ask. Oh, is your joint pain worse when you're using it? Or is it worse first thing in the morning when you wake up where and it gets better with use? Are you stiff for more than 60 minutes in the morning? That's kind of a first telltale.
Yeah, that's good. And then also, are you seeing with rheumatoid arthritis, since it's systemic, you see it bilaterally, both on the right and left joints, as opposed to osteo, where it might be more prevalent in just in one side?
Yes. So the classic presentation of rheumatoid is more symmetric in the smaller joints, the wrists, the MCPs, these knuckles, the PIP knuckles of the hands, and with that swelling. But that's not everybody. So not everyone's going to fit that mold, right? And some people can get rheumatoid, not just in the smaller joints of the feet and the hands and the wrists and the and the ankles, but also it could just be one swollen knee, and that can happen. Some people do present like that. There's plenty of people in my life who present that way, one big swollen knee. And then often we end up drawing fluid out of the joints and seeing how inflammatory the fluid is, and also checking blood work. So it's not always a textbook case, which makes it interesting. Yeah.
And on some of those textbook cases, if somebody looks at their hands and they see ulnar deviation where the hands are veering off to the pinky side, what is the mechanism that causes that? I've always wondered, why is it that you have ulnar deviation with rheumatoid arthritis where those joints start to veer off to the pinky side of the hands?
Yeah, so you're having a lot of inflammatory cells going into and around the joints, and it's causing the synovitis. And it often affects those metacarpophalangeal joints, the MCPs, which if anyone's, the bigger knuckles, if anyone's listening in the car, okay, on your hands. Mm-hmm. And when those get really inflamed, you get some classic changes. You can have subluxation where they kind of turn and deviate down. And then you also get that ulnar deviation when they're inflamed for quite a long time. Mm-hmm. These days, we try to catch it sooner than that, right? Because if you have inflammation, it can happen very quickly. So every 3 months causes a lot of permanent damage. And once the damage is there, it's there, it doesn't reverse. So we want to try to catch these things very early and treat it fairly aggressively to stop these types of changes. It used to be in the 80s or the 70s that people would end up, crippled, right? Now we have quite a few options, biologic medications that target certain parts of the immune system and are able to stop these processes. So I like to find them early. I like to get that early referral.
Yeah, and with autoimmune conditions being on the rise, what do you think is contributing to some of the increased prevalence of autoimmune conditions, such as rheumatoid arthritis?
That is a good question. And I'm sure if I had the answer, maybe I'd have a Nobel Prize in medicine. So I'm not 100% sure.
Okay.
Why we're seeing maybe a little bit more autoimmune disease. But it does seem that people have more antibodies than they used to. There was a study on a certain antibody, and it seems that the prevalence of antibodies are going up in people in general.
Yeah.
I'm not exactly sure why, and
Yeah. Now you've seen a lot of rheumatoid arthritis affect the low back and this inflammatory ankylosing spondylitis and arthritic backs. How does that differ from somebody with a back pain that's caused by osteoarthritis or other means or disc or something?
Yeah, no.
How would we know that? Let's say one of our audience members is dealing with a lot of back pain. What are the common telltale signs that they're going to have if they have the arthritic back that you often treat there in your office?
So, there's a few telltale signs for me. Rheumatoid doesn't affect. It can affect the neck, okay, the cervical spines, mostly right at the top under the skull. But rheumatoid doesn't affect the back. What does are the spondyloarthropathies, okay? So if someone has psoriatic arthritis, which is arthritis, and they also have psoriasis, those patches of flaky red skin, a lot of those patients will also have inflammation. That could affect the back. And then there's ankylosing spondylitis, which is an inflammatory back condition. And there's a few others that fall into that category. So it's a great question because everyone has back pain, right? And I think a third of all medical visits are for back pain in general. So to differentiate when you need a rheumatologist versus mechanical back pain is inflammatory back pain is usually in people under the age of 40, okay, or it starts earlier. And similar to what I was talking about with rheumatoid arthritis, the pain is worse in the morning, okay? So the story is often, it wakes me up from sleep, I'm stiff, my back is stiff first thing in the morning for more than an hour. And it gets better with exercise, okay? Mechanical back pain I mean, the onset is variable. It's, plenty of people under 40 have it also, but it could also be older people. And the pain is usually worse with exercise or with movement and gets better with rest. So this is the opposite. The pain is worse with rest and it gets better with movement if it's mechanical. So that morning stiffness, getting better with movement, and especially over the sacroiliac area is where I'm looking for pain. Okay, there's a few other things that come with it, but if you hit those things, back pain before 40, it kind of comes on gradually, and it's not something that's only lasting a month, or you did something lifting. And the pain improves with exercise and does not improve with rest. And that wakes them up from sleep. Those are the big hitters for me.
Mm-hmm. Okay, got it. And then, so what is your treatment then for that? Somebody comes in, they're having these symptoms that you're mentioning, they come to see you. What do you typically do there in your office for these people?
When someone comes in with that, I look for other signs. Are they having a psoriatic arthritis? Do they have rashes of psoriasis? Do they have maybe an inflammatory bowel disease? Because many of these patients have an overlap with Crohn's or ulcerative colitis, or even a subclinical inflammatory bowel disease where they say, yes, I have diarrhea many times a day. Do they have something called enthesitis, which is swelling of the tendons and ligaments where they insert into the joints? So I'm really doing a very thorough physical exam, looking at their Achilles tendons, and do they have tennis elbow? Do they have plantar fasciitis? Do they have these kind of enthesitis symptoms? I ask about their history. Do they have inflammatory eye disease? I also look at the peripheral joints. They have other joint pain or swelling. And one common thing that folks could have is something called dactylitis. And that's where one finger or one toe blows up like a big sausage, and that could come and go on some of these patients. So, there's quite a history that goes into it. I spend a lot of time with patients, looking at the history, doing a proper physical exam, and then we do blood work. So I look in the blood work, do they have generalized markers of inflammation that are high? And then finally, there's a genetic test. So a lot of people, 90% of people with ankylosing spondylitis will have a genetic marker called HLA-B27. So I'm able to check their blood for that marker. So if they have the symptoms, right, and then they have high levels of inflammation in the blood, and then if they even have the genetics, it's a slam dunk, right? The final thing is imaging. So I look at plain films of the sacroiliac joints, and I look for erosions, little scooped out areas, or signs of inflammation. Fusing of the joints would be fairly advanced, but you could see things like that. So it's a pretty thorough workup to try to get this diagnosis.
Mm-hmm. Got it. And in regards to the general markers that you're looking at in the labs, what are some of the ones that are general that you see in common labs like CRP? Are you looking at, some of these other markers? Can you tell us about that? If somebody has a lab report there from their general practitioner and they're looking at it, what are they going to see that's going to be abnormally high or low or affected?
So patients with inflammation, we look for that C-reactive protein. We also look at the sedimentation rate. Those are the two markers of inflammation that are general, but they're fairly non-specific, right? Anyone could have a higher CRP. There's myriad reasons you could have one. A pimple on your butt cheek could give you a CRP, right? So it's not giving us all the information. I do like that genetic test, the HLA-B27. We also look for rheumatoid factors, another CCP, other antibodies. Okay, there's also lupus-specific antibodies for other conditions. But for the inflammatory back pain, we look for those generalized markers of inflammation and the symptoms. Other signs that someone may have inflammation is even just looking at their basic, their blood counts, right? If they have anemia, that could be an anemia of chronic disease, or if your body is inflamed for a long time, you could have anemia. Your platelets could also be a little bit high. That could be a sign that this person has inflammation. So there's a lot of kind of generalized, we look at a few different things.
Do you find that the general blood work that these patients come in, because I'm sure you have patients that come in from their general practitioners and they bring you their labs. Do you find that a lot of these labs, they're just not running enough tests or the proper tests to diagnose some of these conditions that you're looking at?
Ankylosing spondylitis and non-radiographic AxSpA, which is where it doesn't show up on the x-rays, is underdiagnosed. Okay, there should be as many of these patients as there are rheumatoid arthritis patients, 2.5 million or so in the country, but I'm not seeing them. Okay, and they say it takes on average 5 to 7 years for one of these diagnoses to be made. And these patients end up jumping around to a lot of different doctors and sometimes getting unnecessary medical procedures. Whereas if I were to put them on the right medicine, we could control their inflammation. Even surgical interventions end up happening on them. So they're being missed. That's one of the reasons, talk with you. I want to get the word out there. I want people to be able to recognize these symptoms and know when maybe they should seek rheumatology or talk to their doctor about the possibility of inflammatory back pain.
Right. So let's say somebody moved here to Florida, they're brand new. Hey, I gotta find a doctor here to kind of take a look at me, do a regular physical examination. Would you recommend that they come see you as opposed to like a general practitioner, because you're going to be a little bit more specific, especially if they're dealing with some of these, they just want a general overall health check, but then maybe they're also having some of these inflammatory symptoms. Would you recommend they come see you as opposed to seeing a GP first? Because you're going to be looking for some of these things and you could be bypassing that 5 to 7 year process of finding out what's really wrong with them.
That's a good question. Everyone has to kind of take responsibility for their own health, and seek the care. And many times it's the people who are looking these things up online or are a little bit pushier who end up getting the proper care, right? And other people fall through the cracks. So it's good to be your own advocate if you feel that something's not right. But the primary docs are a great place to start, and I try not to jump the queue. It's better to have them referred over to me, because there's other conditions that could cause pain and swelling and morning stiffness. So maybe it's just their thyroid, right? Or maybe they have uncontrolled diabetes. That causes a lot of aches and pains, right? So there's it's always good to start with your GP and kind of go.
But you having your training in internal medicine, don't you kind of deal with those conditions as well? Thyroid conditions, diabetic conditions, and things that.
Yes. So my practice now, I really do focus on rheumatology.
Okay.
Obviously, I'm going to treat the whole person who's sitting in front of me. And part of my workup is often, I had someone today, I'm like, okay, your joints hurts, but first things first, we got to control your thyroid. It's out of control. Your diabetes is out of control. You're not testing positive for an inflammatory condition. These are your issues. But, just focusing on rheumatology here in this practice, it's always best for someone to also have a GP, because I'm not doing all the regular stuff there. Cancer screenings or blood pressure, treatments and all the rest of it. So it's good to have that quarterback as a GP sending you to me as a specialist.
Yeah.
But some people call me, it depends on your insurance, right? Some insurances require referrals. Some patients could just kind of call up and say, oh, I have gout or I have rheumatoid or I want a second opinion. And I welcome those people.
Right. Okay. So, but you do like this just to narrow in and focus in on the rheumatoid.
Yeah, I like to focus on those things. And, I don't offer all the, I'm not doing your regular cancer screenings and all the GP stuff. That's also important.
Tell us about an interesting case that you've had that you've been able to help, or they were misdiagnosed or they were not, they weren't properly worked up, and you were able to help them using your approach and the testing that you do. And can you think of any?
Yeah, I could think of a few. So on the same topic, I had a middle-aged woman. She must have been in her 50s. And she came to me recently And she carried a diagnosis of fibromyalgia, right, which is chronic fatigue and chronic diffuse pain. And that's where your body is, you're just, things hurt more than you want them to, right? So someone gives you a tight hug, it may hurt more than you would expect. And it usually is coupled with significant fatigue. You're not sleeping well at night, and you have this pain cycle. So she had, she did have actual fibromyalgia, but when on closer examination of her, I found a little patch of psoriasis behind her ear. And then when we did it, she was having a lot of lower back and butt pain. Her x-ray was negative, but she did have high markers of inflammation, right? So she ended up having a psoriatic arthritis, where she's like, yes, I have, and she didn't say I have enthesitis, but I was finding out that she had enthesitis. She was getting tennis elbow, plantar fasciitis, Achilles issues, inflammatory bowel disease issues, and we ended up treating her for a psoriatic arthritis, and she was a painter, and she actually made me a painting and said, you saved my life and I could do all these things again, and I feel so much better, right? So it's nice when you find these inflammatory arthritis issues. She still does have some fibromyalgia and some chronic fatigue, but overall she's much better.
Fibromyalgia, that's a whole nother story in and of itself, right? I'm sure you get a lot of people that come in that have been diagnosed with fibromyalgia. Can you talk a little bit about fibromyalgia there? Because it is quite a few.
Right? Oh boy, I opened up a can of worms on this one.
You opened up Pandora's box. We have a few minutes left, but maybe you can just kind of distill your thoughts on fibromyalgia.
Fibromyalgia is one of my passions. I feel like I could say that about a few things, but it's a very interesting issue because a lot of people have it and they go underdiagnosed. So I just want to say, first thing, fibromyalgia is a real diagnosis.
Yeah.
It's not, a lot of docs still think, oh, it's just, people with chronic fatigue.
Catch-all, right.
It's a catch-all. But if you take a patient with fibromyalgia, and there's a great doctor at the University of Michigan, Daniel Claw, C-L-A-U-W, who's published great studies on fibro. If you take these patients and you put them under a functional MRI and look at their brain and stimulate them in one way or another, you will see that their brains light up. If I were to touch their chest, let's say, their brains are lighting up as if I'm throwing hot coffee all over them.
Right. Yeah.
And it's
you barely touch them and they scream in pain. You're.
Yeah. So we used to use tender points as a way to judge. There's different criteria now. And you can go to the University of Michigan site, and there's a self-assessment. If you're curious about fibromyalgia, you could do a self-assessment, see if you have it. There's a fibro guide there. I'm not affiliated with them at all, but they do just great work for fibromyalgia. So I'll put that out on your podcast. But it's a real condition, and what it is your volume is turned up. So things that other people wouldn't recognize as painful, a dog jumping on your lap or someone giving you a tight hug and a slap on the back, you're feeling much more than others. And it does come with this chronic fatigue. And it also comes with anything you put in your body, you're going to feel more than you want to. So often the patient will come to me and they'll have a big allergy list. Mm-hmm. It's not even that they're allergic to these medicines. They're just more sensitive to anything that they're going to touch. And they'll often have chronic headaches. They just feel them more than someone else would. IBS, or irritable bowel type syndrome, constipation, diarrhea, pelvic pain, interstitial cystitis, where urination hurts. Their whole body, any part of their body could hurt at any different time. So they feel these things, and unfortunately they end up getting a lot of surgical procedures and unnecessary procedures. There are pretty good treatments for fibromyalgia to help. There was a great study published in the New England Journal of Medicine on Tai Chi, that patients who do Tai Chi, it really does bring down their pain levels. And then I use certain medicines. One medicine that is really good is a muscle relaxer, Flexeril or cyclobenzaprine. Mm-hmm. And that helps my patients in the evening. I tell them to take it kind of 2 hours, let's say, before bed. It helps them get to sleep. And if you have a restful night's sleep, it will definitely help your pain level. The cornerstone to treatment is things like low impact aerobics and Tai Chi, and just really moving a lot. And that brings down your pain levels. The worst thing someone with fibromyalgia could take is an opiate, because it causes more pain sensitization. So I recommend staying far away from those.
Mm-hmm. And why is it that movement helps with the patients with fibromyalgia? What's the mechanism there that movement brings them such relief?
So when someone has fibromyalgia, you could imagine it as their central nervous system, their volume is turned up. So they have these ascending pain fibers, let's call them. And when you do exercise, you could cancel those out or create kind of a descending pain blocking pathway. Where if you do more exercise, your body naturally blocks these types of pain signals. So I always encourage that, and it also releases certain natural hormones and endorphins, but it does seem to block this ascending pain pathway.
Well, it sure does keep them accountable to moving and exercising, because when they stop, they're in big trouble.
Yeah, you never want to stop. And I start slow. You could do something on YouTube, a chair yoga or a Tai Chi, every day. You don't need to start joining a class, just to do something every day, right? 10, 15 minutes, just to force yourself to make sure you keep. Yeah.
Well, hey, this has been a great show. Thank you so much for your time. I know you got a really busy schedule, but this has been fascinating. I think you shared a lot of insights that our audience will be able to take away with them. And how can people get a hold of you, Doc, if they want to make an appointment or?
Sure, yeah. So our office, it's called One Rheumatology, O-N-E, and then rheumatology is R-H-E-U-M, atology. Okay, so it's One Rheumatology. We're here in Palm Beach Gardens. We have a website, and it's www.rheum.one. So it's not .com, it's .one. Rheum.one is our website, and anyone can reach me through there. I'm on TikTok also and all the rest of it, but Rheum.one is the website where anyone can find me.
Great. And do you have a phone number too? Do you have a phone there at your?
Yeah, we have a phone number, 561-559-1110. And no prank calls, but we're happy to help here for sure.
Yeah, great. Well, hey, thank you so much for your time and expertise. We really appreciate you taking the time to share your knowledge with us.
No, I really appreciate you and your podcast and everything you do. So thanks for having me. And there's so many topics that we could really do a deep dive on. So if anyone wants to learn more, I'm sure they'll reach out to you, and I would, be happy to come back. So I appreciate you.
Okay, great. All right.
Thank you.
Thank you, Doc. All right.
Bye.
Thank you for listening to the Taylor Method for Pain-Free Living podcast. For more information about the Taylor Method and how you can find lasting pain relief, visit www.drderektaylor.com. That's www.drderektaylor.com.